It's a pleasure to have one of our own here this morning, Michelle Keir. Michelle is a clinical associate professor at the Libin Cardiovascular Institute. She's the medical director for the Southern Alberta Congenital Heart Clinic, and she's also the cardiology lead for the PLC and our EDI lead for the division. And it's in that capacity that really she's going to talk to us today about equity and endocarditis, and are we providing the best care for our underprivileged population, our patients living with addiction, those experiencing homelessness and poverty. Michelle, nice to have you.
Yeah, thank you, Catherine. So everybody, this is one of our Equity Grand Round series. So it's meant to have some time at the end for some discussion. I'm told that the mics in the room are significantly improved from last time we did this, so I'll unmute when we get to that section. And also we've got people online. Oh, somebody's in the chat. Oh, it says cannot hear you well. Can you hear well now? Okay, I'll stand closer to the mic. Okay. So we're going to be chatting about management of endocarditis in vulnerable populations today. So I'm going to start with a land acknowledgement. So the University of Calgary, located in the heart of Southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki Bearspaw and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta. And then I'm just going to go through conflicts of interest. So I don't have any commercial interest to declare. I do want to declare very upfront that I am not an addiction medicine specialist. We have amazing addiction medicine specialists through the Department of Internal Medicine and Family Medicine in Calgary. And I'm also not a medical ethicist. So the lens that we're talking about this today is through the cardiac sciences lens and how we can improve care of these patients within our division. There will be some references at the end if you want to dig further into the addiction medicine perspective, but I'm going to talk about it from the cardiac sciences lens. So what are our objectives? So we're going to go through a case example. I'm going to chat a little bit about the epidemiology of endocarditis in people who inject drugs. We're going to talk a little bit about the language that we should be using because that's shifted over the past few years. Even looking through a lot of the cardiac literature, it's a lot of IVDU, which really centers the behavior instead of the person who's living with it. And so the new terminology is people who inject drugs. And we'll talk a little bit about terminology later. Challenges in the longitudinal follow-up of people experiencing homelessness or the unhoused, and a little bit about medical care of the incarcerated in Canada. So I'm going to start with patient AB. So he's actually a patient of mine. He's a 44-year-old man who had recurrent DVTs and so has chronic venous stasis from that. Unclear etiology because no thrombosis workup was ever completed. He kind of presents for acute care, gets hospital care, but there's never any outpatient care. He has a history of polysubstance use disorder, and he's currently on methadone. He's had Staph aureus endocarditis, so partially treated 2018, partially treated 2019, and then again in 2021, where he had severe aortic regurgitation and large vegetations. So he underwent surgery in 2021 with bioprosthetic aortic valve regurgitation and aortic valve replacement, and after that he had no longitudinal follow-up. So I had attempted to follow up with him, no fixed address, no telephone, and so was not in follow-up. He had been experiencing homelessness until incarceration began about 6 months ago. And I think it's important that he was incarcerated for nonviolent drug offenses. So, and with the incarceration, he told someone on his medical intake that he was having exertional shortness of breath, and so he was re-referred back to cardiology clinic, and I saw him in clinic. So he's short of breath with severe exertion, with minimal exertion. He has terrible dentition. He's found to have a paravalvular leak and/or fistula from the aortic root into the left ventricle. And so the question is, what do we do next? So special challenges to guideline-based care in patient AB. So I think some of them came from the case originally. So polysubstance use disorder in someone with recurrent endocarditis, how do we manage that? He is experiencing homelessness, or he was until he was incarcerated. He's currently incarcerated, so how does that affect his medical care, and then also his lack of dental care. How does that affect his long-term outcomes? So how do we help a patient like AB in our province today? So I'm going to chat a little bit about injection drug use in Canada, and we'll chat a bit more about our policies within Alberta and how those have changed in the past 5 years and how that's affected what we see on the cardiac sciences department. So from 2011 to 2016, so this is even pre-pandemic, the number of Canadians who inject drugs increased by 32%. Drug-related poisoning deaths have steadily risen across Canada from 2016 to present. I want to note there that it says drug-related poisoning deaths, so that's the terminology that we're moving towards. So a lot of the old literature would say overdose, but because the focus is now on the fact that this is an unsafe drug supply, and that's why a person has died, the new terminology is drug-related poisoning death. And if we look at Alberta, over 7,000 people have died of opioid poisoning in Alberta since 2016. So this is not endocarditis. This is just an assessment of injection drug use in our province. This is data from Quebec, so direct healthcare cost of IV drug complications. And this is a cost-effective analysis, but you can look here, the green line is injection-related infections, and that includes endocarditis. And you can see that that's steadily rising, and then the percentage is year-over-year cost of these patients to the healthcare system for being admitted and having cardiac surgery, et cetera. And so you can see that the total number of IV drug complications has increased significantly, as well as endocarditis. So this is not a problem that is getting better or is going away. So what about harm reduction in Alberta? So what are we doing to prevent these injection drug infections? So a lot of this was taken, Dr. Kate Kalitza, who's an addiction medicine specialist internist at PLC, did an analysis of harm reduction and the policies in Alberta. And so this is actually available on YouTube. It's about an hour and a half watch, but it's an excellent watch because they go through all of the policies. But since 2019, Alberta's safe consumption sites have had their funding threatened as government policy moved to an abstinence model. And so this is a quote, "A certain shroud of stigma needs to remain around addiction." And this is a quote from Marshall Smith. So I'm not sure if anybody in the audience knows who he is, but he used to be the chief of staff to Danielle Smith. He's somebody who refers to himself as a recovering addict. Again, addict is not the term that we should use, but that's how he refers to himself. And he's created a lot of the policy regarding Recovery Alberta and management of patients who use drugs in Alberta. And so the focus has moved away from harm reduction to recovery from addiction. So there's been an essential, what we call a ban on safe supply since 2023, but OAT programs remain. So this was something that I wasn't aware of. So OAT is opioid agonist therapy. So that's Cadian, methadone, longer acting compounds that prevent withdrawal, but the goal is focused on recovery and eventual abstinence from narcotics, whereas safe supply is physicians in a safe environment prescribing a short-acting or even a long-acting opioid, so hydromorphone, et cetera, so that the patient is able to use drugs safely and not be worried about dosing on street drugs. So as of 2023, there's been a pretty much blanket ban on safe supply. That's there's some nuance to that. There's apparently 2 places in the province that it can be prescribed, and the doses have to be observed. So it's essentially inaccessible to most patients. And it's actually illegal for physicians to prescribe safe supply medications. So that's the environment that we're working in and that where we're seeing the current epidemiology. So rethinking management of endocarditis in people who inject drugs. So there is some new evidence looking at how we manage these patients. So often they have right-sided lesions. The traditional management was non-interventional, so IV antibiotics. And the thought is that maybe that leads to more morbidity and mortality than doing something about it. So there was a trial called the Clear IE, a registry, not a trial, that was just published in JACC in 2025. And so this was looking at catheter extraction of large vegetations on tricuspid valves. And so 43% of women, which is good for a cardiac study, and 51% had a history of injection drug use. And again, Staph aureus was the predominant pathogen. So this is exactly the patient population that we see. And so this showed feasibility and safety with reduction in vegetation size. So the average vegetation was 2.5 centimeters, which is quite large, down to 1 centimeter. And so the next step is RCTs to assess long-term outcomes of whether these catheter extractions are a good option in these patients. But in the absence of catheter interventions, what about surgical outcomes of endocarditis in people with a history of injection drug use? So this was a trial from 2023 where they looked at 192 patients undergoing surgery in Helsinki, Finland, from 2005 to 2016. And about 25% of them are people who inject drugs. They found that patients, again, who used drugs were younger, had less cardiovascular risk factors and lower Euro scores, so lower surgical risk, essentially because they're younger. Most of patients who injected drugs had Staph aureus infection, and many of them had tricuspid valve endocarditis. And liver disease occurred more often in those patients, and that tended to be hepatitis C related. But if you look at outcomes between patients who inject drugs and those who don't, with endocarditis, the 30-day and 5-year mortality are similar between the two groups, although there is a higher risk of reinfection and reoperation in people who inject drugs. And there's multiple smaller case studies, and this essentially shows the same thing, that the surgical outcomes are similar in these patients compared to patients who develop endocarditis for dental infections, et cetera. What about one of the arguments that we hear about surgical risk to healthcare practitioners? So I think this is really important to mention because I've heard this before that, well, it's a big risk to the healthcare team to operate on patients with hepatitis C and HIV. We don't want to do it. We're putting ourselves at risk. We shouldn't operate on these patients. We should treat them medically. So this is just some reminders about exposure risk. So exposure to an infected needle, blood, or secretions carries a risk of transmission of 9 to 30% of hepatitis B, 1 to 10% of hepatitis C, and 0.3% with HIV. So the rate of transmission is really quite low. A review of surgical procedures on HIV-positive patients at the Royal Free Hospital, so that's in London, UK, revealed no transmission to healthcare workers with no needle stick injuries in 477 operations. So these were mostly intra-abdominal, not cardiac, but there's a really low risk to healthcare practitioners. Despite that, so this was a study from Nigeria where they asked their surgeons what their level of anxiety was around contracting HIV from a patient during surgery. 94% of them rated their anxiety very high. So I think that tells us that we're over-concerned about the risk of infection to healthcare workers in this patient population, but it's really a significant reason and a barrier for these patients to receiving care. If you look at the US, so since 1981, since they started collecting this data, there's only 57 documented cases of occupationally acquired HIV seroconversion since 1981. So the risk to healthcare practitioners of operating on patients with HIV or hepatitis is extremely low, and so it should not be a barrier to care for this patient population, although it's something we hear quite often. And I think this is an important example. So if we look at hepatitis C, about 80 to 95% of people who inject drugs are infected with hepatitis C, but treatment with novel therapies results in clearance of the virus in 95% of patients. In 1997, when these medications came out to clear hepatitis C, the NIH, so the National Institute of Health in the US, recommended that people who inject drugs not be offered treatment for hepatitis C unless they've been abstinent for 6 months. So this was the original guidance. And again, it's this focus on abstinence. We're not going to treat these patients until they have proven that they can stay abstinent for a period of time. And obviously that's been shown, that guidance has been reversed because studies show that people inject drugs have adherence rates to treatment of 40 to 80%. So similar to other subsets of the population. Harm reduction techniques, so sterile needles in a safe injecting environment, reduce reinfection rates, and a policy of, so this comes from the NIH document where they reversed that decision. So a policy of deferring the treatment of hepatitis C infection indefinitely for patients who do not have access to drug treatment programs effectively abandons those most affected by the hepatitis C epidemic. So they've certainly changed course on this and said now yes, we want to get you treatment for your polysubstance use disorder, but it's not a barrier to receiving care. And I think that example should hold for cardiac surgery as well. This is also a quote from that document where they reversed the decision. So low rates of adherence are common, for example, among patients with hypertension, asthma, and diabetes, nor are patients whose behavior could cause a recurrence in the condition generally denied treatment. So we don't say to a smoker that they can't have a coronary artery bypass surgery unless they've been abstinent for cigarettes for 6 months. And we would never say you shouldn't have treatment for emphysema because you've continued to smoke. Persons with alcoholic liver disease are not denied treatment for GI bleeding or ascites. We would never say to a commercial sex worker or others who engage in high-risk sexual practices, we're not going to treat your STI and because there's a risk of reinfection. So in fact, they're specifically targeted for treatment in order to prevent the transmission of disease. So essentially, yes, this is a barrier to care. Patients who are injecting drugs, and it is a risk factor for reinfection and the original infection, but it is not an adequate reason to deny care to these patient populations for many reasons. So what about long-term outcome of, so this is another term that in the US they've moved to using. So instead of infective endocarditis in IV drug users, the term is now drug use associated infective endocarditis. And so what are the long-term outcomes? So a lot of this data comes from a position paper from Jack looking at treatment of drug use associated infective endocarditis. It's very comprehensive and a really good read. So after you watch Kate Kalitza's webinar on harm reduction in Alberta, then you should read this Jack paper. But I'll take some highlights from it. So long-term outcomes of drug use associated infective endocarditis. So the overall survival is 74, 63, 58, and 44 at 1, 3, 5, and 10 years respectively. So really excellent long-term survival. The most common cause of death is relapse or recurrent episode of endocarditis, which occurs in 55%. So adverse outcomes are attributable to ongoing infection. In a small Norwegian cohort, they found that 70% of patients continued injection drug use after their first operation for drug use associated infective endocarditis, and 44% continued after their second operation. So obviously there's a target for harm reduction here that we are not missing. So we are fixing one problem, but we are certainly not helping in the long-term problem. And so how do we do that better? So this is also from that position paper. So what they advocate for, and I know Dr. Adams has advocated for endocarditis teams where infectious disease is involved and social work is involved and dentistry is involved. But in the US, they're now advocating for drug use associated endocarditis teams. So that's a wider team that involves addiction medicine, social work, psychiatry, all the different options to help these patients do well in the long term. I think one of these are, so on the left, you can see the high-risk features of drug use associated infective endocarditis. And the one I highlighted there is withdrawal symptoms and pain management needs. So if these are not managed adequately in hospital, and from the document that was created by the Alberta government on safe supply, there were a lot of comments about, well, we shouldn't be giving people free drugs. We shouldn't be giving, and again, the term addict is not acceptable, but we shouldn't be giving addicts free drugs in hospital. They're just coming into hospital. So all of these biases prevent patients from getting their withdrawal symptoms treated and their pain management needs treated post-op, because this is a much more complicated issue in somebody who's using opioids long-term. So this is a target we're clearly not meeting withdrawal symptoms and pain management needs. And then if we look at one of the outcomes of that, one of the big outcomes is self-discharge. So patients leaving hospital on their own because we're not adequately managing their pain needs in hospital. And then again, they lose out on all of these other resources because of an upstream problem. And again, this is in the US. They've anecdotally shown that these drug use associated endocarditis teams are associated with improved rates of full antimicrobial treatment, decreased readmission, decreased incidence of reinfection, and longitudinal follow-up with addictions medicine team. So engaging in this way could be an important way to improve care for these patients. And this is their diagram of the people that they feel should be on this team. when you look at this now, I went through it and thought, oh, well, okay, so we definitely have a cardiac surgeon. They take out the endocarditis. We definitely have an infectious disease specialist who provides the treatment recommendations. And there is usually a cardiologist involved at the beginning where we diagnose the endocarditis. But a lot of the rest of these pieces are missing. So yes, at PLC, we're really lucky. We have addiction medicine specialists. We had the ARCH team, which is no longer, but they still have a consult service. So they are really helpful in providing treatment for these patients in hospital, but are they getting that treatment at Foothills where they come for surgery? We definitely don't have a case manager to ensure safe discharge of these patients. In fact, many of them self-discharge on their own. And then we certainly don't have engagement with the primary care team, aside from us just sending a note to the family doctor saying this person was in. So I think this is a challenge, but there's lots of really clear targets that we could aim at here for quality improvement in the longitudinal care of these patients. Another piece that I think is really important that we don't focus on is, sorry, Steve's chat GPT is is engaging. Yeah. Okay, sorry. So this was a slide, this is a summary of principles of trauma-informed care. So, we've learned this over the past few years that if you look at up to a third of women and a quarter of men have experienced some form of sexual assault, if not assault. And so using trauma-informed care is really important in all patients, but especially in those with a history of addiction, because their rates of assault are higher than in the average patient. So these are things that are targets, but I certainly don't think we're doing. So focusing on creating a welcoming and safe environment for patients, acknowledging that healthcare settings can be a challenging place for patients with a history of trauma. Also for our Indigenous patients, ensuring that they're comfortable in a healthcare setting where they had significant racial bias in the past. So this is a target that I don't think we're using. We're reaching, always using first-person language and avoiding stigmatizing ways of describing substance use or people who use substances. So we'll chat, that's the next table, we'll chat about language to be avoided when we take care of these patients. This one, I think we do a terrible job at. So attempt to have consistent healthcare providers and to limit the number of providers in the room at one time. And when I read that, I cringed because I thought the number of time I've walked into a room with like 6 trainees behind me and everybody trailing and, nobody really knowing the patient. And so we should be limiting this in patients that we know, in all patients, but especially in patients that we know have trauma or maybe uncomfortable being in hospital. This is good advice. So when possible, don't stand over patients, sit with them, meeting them at eye level. Always ask to touch the patient and move the patient's belongings if necessary. I see this, every time I'm in the emergency department and we call for an ECG and, the ECG techer comes and we're just putting the stickers on the patient and not saying, do you mind if I touch you here? Do you mind if I move can you move it for me? Those sort of things. So all of those behaviors that are really kind of standard in the hospital can cause more harm to these patients and increase the risk of self-discharge in this patient population. And again, elicit patient subjective needs and when possible, try to meet these needs. So, if the barrier to staying in hospital is, I need to go to the bank for an hour, and we say, well, you can't have an hour off tele to go to the bank, then that person is going to self-discharge. So knowing what those needs are, knowing what's preventing a person from getting adequate care and trying to negotiate with patients to meet those. And then again, allowing them to express their goals, preferences, and agency. And then again, let them know that you're there to collaborate. So instead of a top-down model, that we're trying to work with you to improve things. So these are important in all patients, specifically those who have experienced trauma, and extremely important in people who inject drugs. And then I thought this was a great reminder of language. So things that we should, and especially avoid, because even just going through the cardiac sciences literature on drug use associated infective endocarditis, you couldn't copy and paste anything because there were a lot of this terminology throughout. So addict, user, substance, or drug abuser, all of those should be removed. We should not be using that. So here's the terms. And again, it's all first person language. So this is a person first, not their drug use, right? So they're a person who is suffering with one of these problems. Substance use disorder, drug addiction. And then I think this is important because we use this terminology interchangeably, but so we often say substance use disorder is substance misuse disorder. And I wasn't really sure what the definition was, but substance use disorder is any illicit drugs. Substance misuse is where prescription drugs are being diverted for misuse. So if it's an opioid medication that the person was getting a prescription for and then now is not able to and is getting drugs from the street, then that's the change. So that's a substance misuse disorder. Everything else is a substance use disorder. Talking about recovery and treatment, so medication treatment, not opioid substitution or replacement therapy, and whether they're clean or not is a big deal. So that's not a term. Just the language of it, if you think about it, we're saying a person is clean or unclean, right? And what that does to a person, just that language, the way that we're using it. So the language we use in medicine is really, really important. So we should never be referring to someone as clean or unclean. So they're either in remission or recovery or abstinent for drugs or not drinking. And then this is more in the US, but there's a lot of talk about babies being born addicted, which is not a thing. So babies born to a parent who used drugs while pregnant is the terminology for that. So I'm just going to move on and we'll talk a little bit about my patient AB's additional challenges to seeking care. And I don't have any great options for fixing any of these problems. So if anybody has any ideas, that would be great. But I think recognizing them is a big part of the battle. So knowing that the term people experiencing homelessness, so PH, includes people without accommodation, people living in temporary or crisis accommodation, so emergency shelters, and people living in severely inadequate and insecure accommodation. Health inequity in this population results in higher morbidity and mortality across the board from all conditions. 37 and 22% of people experiencing homelessness in Canada are living with alcohol and drug use disorders, respectively. And 53% of them, I think this is really an interesting statistic, have some degree of traumatic or acquired brain injury. So everybody's worried about the football players. And their CTE. But what about our patients who are living in difficult accommodation or experiencing homelessness, really high risk of acquired brain injury that puts them in a precarious position, and then really high risk of assault in shelters or crisis accommodation, which then makes the problem worse. So we're essentially saying, to people that have difficulty with executive function because of trauma they've had in their past, this is how you need to engage with the healthcare system, and it's complicated for people who don't have a traumatic brain injury. And I think this is just a number from Calgary. So in October of 2025, there were over 3,000 people experiencing homelessness in Calgary, and a 12% increase from 2022. So these numbers are only increasing. If we assume that 20% of those 3,000 people are living with a drug use disorder, even if 5% of them are living with are injecting drugs, then think of the number of infections that we're going to be seeing. So I just wanted to drive in that this is not a problem that's going to be going away. And so how we deal with it is important. So what about additional challenges? So I had said in the beginning that patient AB is also currently incarcerated. The good news about that is that he was able to say to somebody, can you please call my cardiologist? I'm short of breath. And they were able to make him an appointment. They brought him to his appointment in an orange jumpsuit and chains for somebody who's incarcerated for nonviolent drug offenses. So I didn't love that. So that's a barrier as well. But also he at least was able to access some degree of care. I think there's also the thought that, oh, well, why don't we just lock these people up and they won't use drugs? That's actually not the case at all. So this is data from the Corrections Canada National Health Survey from 2022. So 12% of incarcerated individuals inject substances while incarcerated. Most injected 1 to 3 days per week. The most commonly injected substance was methamphetamine, and 2/3 shared needles. So this is during incarceration. So clearly that's another target for harm reduction. And all of these patients are probably going to be, many of them are going to be coming our way. So you can only imagine the risk of endocarditis in this environment. So for my patient, even when I saw him and said, we're going to order further testing. So he had an angiogram that showed he has a giant paravalvular leak. His blood cultures were negative. I'll talk about it a little bit at the end. So it probably isn't an acute infection. It's probably more subacute. But his dentition is terrible. And so we called Corrections Canada and said he needs to see a dentist. He has ongoing risk for endocarditis, possibly has endocarditis currently, and they said the wait to see a dentist is 3 months, and the only service they offer is extraction, which is a large barrier to patients, because if the option is they're going to pull all your teeth and then you're 40 years old with with dentures or unable to afford dentures because that's not covered, how do you eat? So it's also a big barrier to dental care. So he's currently waiting to see a dentist, even though we're quite sure we're going to have to operate on him or have a percutaneous intervention on him, but we can't get him in to see a dentist. So what happened to him? So I'm just going to say the initial blood cultures were negative, so we think it's more subacute, that he wasn't actively infected. He had an angiogram that was completed that showed a significant paravalvular leak. And again, I think that organizing these testing on somebody who's incarcerated is extremely difficult. And so it took real buy-in from administrators who were able to book these testing, work with Corrections Canada to get the patient in. TEE and CTA are pending. And then once his testing is complete, we'll have a multidisciplinary discussion about surgery or intervention. But will we include those other members of that team? So I will stop there and leave the last half of the session for discussion. I'm just going to unmute the room. Okay, so the room is unmuted, and I've got the chat up here. So if anybody online would like to enter anything in the chat, and you should all be able to hear the discussion in the room. So any thoughts about that? I've made everyone look really depressed.
Yeah, kind of.
Yes, yeah. Yeah. So from people in the room or on the line who are caring for these patients, was there anything surprising in that information you saw, or?
One of the things that I wondered about, you talked about the discharge summary, going to the family doctor. How many of these individuals actually have a family doctor?
Yeah, I mean, I think that's a huge issue, right? So, so should we be calling and speaking to the primary care practitioner, even if they have a PCP listed? Are they engaged with that person? Are they going to see them, right? Probably not. So, even for this patient, every time he gets admitted to hospital, I get his discharge summary. I try to book a follow-up appointment with him, but he's not going to come because he has no fixed address. We have no way of contacting him. So I think, just sending the discharge summary and say, well, follow up with this person in 3 months or book an appointment in 3 months. We all know that's not going to happen, right? So we're doing it because it's the process, but we need a better process. Yeah.
We do need a better process. And I was just wondering as I thought about this, because as you said, this is very depressing. So what about organizing it so that when they do leave hospital, there is a family, there's a center set up that they are engaged with as they're leaving or before they're leaving. So they have someone to contact, because I'm willing to bet that most of them do not have a family doctor.
Yeah, and I think it's a big target that we're missing. And I think that's also when you look at the self-discharges. So because we're not managing post-op pain appropriately in these patients, many of them will leave hospital early or say they want to be discharged or leave against medical advice, but really they're leaving to be adequately treated, right? And so it's a huge target that we're missing because we're not setting up that post-op follow-up.
Right.
Yeah.
I also wondered about the extractions, the dental work, because sometimes when we send our patients for dental work before they get their device, because the dentition is so bad, one of the barriers is that they have to pay for it.
Yes, yeah.
What happens when they're incarcerated? Is it paid for, or are they expected to pay?
No, so it's covered, because I did call and ask them about this for this patient. So it's covered, but it's only extractions are covered. So they're not going to, do fillings or cleanings or dental work. They said they have one dentist and she's a puller, was their terminology.
Great job.
Yeah. So yes, it's covered, but it's not adequate care, right? And if you're a 40-year-old man who's experiencing homelessness, then you have to figure out how to purchase dentures or get dentures because you can't eat anything but soft foods, right? So it's a huge barrier to just leaving infected teeth in, which is a huge barrier to safe device health. Yeah.
Have we tried extracting vegetations here? Now, I know we do it sometimes.
Yeah.
When we're extracting leads, if there's a large vegetation, we can suck it out. But I haven't heard of us doing it otherwise.
So I'm looking at Steve. All the mics are on now. But so I know with devices, it's been done a few times, but I don't think we're doing it routinely for tricuspid valves.
There's the one to ask, actually. I don't do.
Oh, okay, yeah. Sorry, yeah. So yeah, but there's not great evidence. So that was a feasibility trial that showed success. So right now we're not. If you look at the number one cause of morbidity, mortality in patients with right-sided endocarditis, it's usually septic emboli or septic pulmonary embolus. So it's a huge target that we're just letting happen in these patients. But based on the guidelines, the treatment for right-sided IE is still medical therapy. But again, we know that these patients are probably going to be reinfected. They now have severe TR, living with severe TR. What does that mean? So it's a huge target for morbidity and mortality that we're missing.
The other thing I noted was the new acronyms. That's one of my beefs. When you get a letter or a discharge summary for outside of cardiology and you have all of those abbreviations or these acronyms, and I had to go look them up, and now you have a whole new list of acronyms. I'm sure the family doctors, if they get them, get this patient, what the heck?
Yeah, so I also am not a fan of acronyms or eponyms, but I do think that the person-centered language is important. Even in the past 15 years, if you go through the literature, a lot of the original trials were, we enrolled this many addicts and, this many were clean and this many overdoses. And so I think that the terminology is really important. It's important to patients and it's important in the way that we talk about patients, right?
Just make sure that when you send out the discharge summary, don't put those acronyms.
Yeah, fair enough. We can do long form. Yeah. Yeah. No people experiencing homelessness. Yeah. Yeah. Okay.
Any other questions? Chat.
Oh, there's some in the chat. Okay. Ben Leese is on the line from Saskatchewan. Yes. So,
hey, thank you so much for that presentation. I was invited through a back door, Dr. Shaw. One of your fellows was kind enough to tell me about this presentation. Thank you so much. So I was really impressed with your presentation. And I know in Saskatoon, we've made special efforts since 2023 to try to address this massive problem. And we have found our multidisciplinary team with our very dedicated care coordinator and peer support has been pivotal in engaging patients and providing longitudinal care. So I would, strongly encourage anyone who's interested in pursuing that. I've found it so rewarding in my practice to be able to reach these people because as physicians, we just can't, right? We can't get through the red tape. We can't build the relationships that some of these allied health people can. And so that's been a game changer for us. We do way more operations than we used to because there's way less bias. And it's been a really rewarding experience in terms of, teamwork. And then just the last thing I wanted to say is Dr. Adams, I'm not sure if he's there, Dr. Corey Adams, but he and I were lucky enough to be part of a group of folks across Canada who actually came out with a bit of a practical recommendations paper on this, which will hopefully be in the CJC in a few months. So look forward to hearing anyone's thoughts on that document. But great job, Dr. Keir. Thank you so much.
Yeah. Ben, do you mind if I ask you, just because, so I think one of the big barriers in Alberta now is the political climate, which has changed quite significantly, even just in the past 5 years, where we did have some kind of robust harm reduction opportunities and we had excellent addictions resources, and that narrative has switched quite a bit. And I remember the politics in Saskatchewan were anti-harm reduction a decade ago. Have you seen a change there, and in what direction, and has that helped?
Yeah, that's a good point. That's definitely an Achilles heel for us. We politically are very against harm reduction. It is part of our routine discussion with patients is safe consumption. And we do support them in wherever they're at. And I think that's the key. It's like some folks are not ready to or some folks, their goal is not abstinence, their goal is to reduce use. And so I think the buy-in in the Division of Cardiology was really like, if that patient's engaged, that's what matters, right? And so as long as we're making progress toward rehabilitation, that's the metric of success rather than abstinence. But it's true that our risk of reinfection does seem to correlate with whether they're housed or not. Major housing crisis in Saskatoon, but we managed to, house a lot of patients thanks to the, dedication of our care coordinator. But also lack of harm reduction access has also been an issue. So we're actively working on it. But yeah, it's a process.
Thanks so much for that.
How is it funded?
Oh, then Dr. Kavanagh was asking how your care coordinator is funded.
Great question. I apologize. I'm talking so much now. I'm getting a bit.
No, that's okay. Yeah, you're.
But yeah, so our care coordinator started as a research grant actually, and then the government provided bridge funding because we were able to demonstrate such an improvement in outcomes. Like we reduced ED visits for this population, which is a major priority, of course, for the government. And so we received bridge funding last year. And so now we're really hoping that her position becomes permanently funded, but it did start as a research project. We hope to publish our results actually this summer, so stay tuned.
That's great, thanks. Yeah. Oh, in the chat, okay. I'm just gonna end my slideshow here, guys, sorry, because I can't see the chat. Okay. Great. Okay, I'm not going to read this whole thing, but it says community resources like Connect to Care team with CUPS Health. Not every client will be eligible and there's a wait list, but those with 6 ED presentations or 2 admissions in the last year could be eligible for advocacy and case management. So yeah, I think that's an amazing resource, especially with CUPS. The problem is I think we're just not utilizing it. So I think collaboration with our cardiac surgery wards, our cardiac teams to say these are the patients that would be eligible for that would be really helpful. So yeah, thank you so much for that comment.
Does anybody know what CUPS is?
Oh, I don't know, Aiden, so someone's on here from Community Partnership, Aiden JH. Do you want to unmute and explain to us what CUPS is and how we can utilize that?
Yeah, absolutely. And yeah, thank you so much, Dr. Keir, for that talk. I really appreciate it. So CUPS is a primary care clinic downtown Calgary, primarily serving folks who are below that low income cutoff. Might be substance users, might be Indigenous folks, might be newcomers to Canada. In any case, very trauma-informed approach. Many doctors on site. We've recently switched to team-based care to maximize accessibility. They've got a few outreach programs. So Connect to Care specifically works on kind of offloading those high users that are accessing emergency rooms and trying to connect them to primary care, specialist care, and then they're saddled with a case manager who can secure income, deal with food security, assist with housing, accompany to appointments and transport, which is obviously a big barrier. Yeah, and then there's a sister team that I work with more on the palliative side of things. Don't get a lot of endocarditis, heart failure referrals, but I'm sure we could. And yeah, like I said, just we can have our teams come in and talk to the team at the cardiology unit and kind of discuss how to go from here.
Yeah, I think that would be excellent. So we may inundate you with heart failure referrals and people experiencing homelessness or post-endocarditis patients. So you let us know how many you can take.
Yeah,
we have many.
and I think it's fair to refer as many as you can, right?
Yeah.
Working with unhoused folks and people who use substances, it's kind of like our bread and butter. We can use the CUPS name as a bit of credibility and, reach out or go down to the shelters directly to make contact with a lot of these folks.
Wow, that's an amazing service.
How does one make a referral?
Oh,
Oh,
sorry, it's hard to
oh,
hear
sorry.
everyone except for,
Dr. Kavanaugh was asking how she makes a referral to you. So we might have to
yeah.
send that information out afterwards. We'll connect with you.
Yeah, no, absolutely. There's no Connect Care referral at this point in time. I think they're working on that, but let me post a link for the referral in the chat.
Excellent. Okay. Yeah. Any other comments or thoughts from the room? Yeah.
More for Aiden, just wondering what's the percentage of usage for cups, like the homeless population, right? Like 3,000, that's only 1,000 would utilize it, or is it like 3,000 of them will go to cups? Like,
Yeah. So there was just a question in the room. Again, this is for Aiden. Thank you for engaging. What percent of the population experiencing homelessness are you guys reaching at this stage?
Oh, you know what? I don't have those stats. It's probably less than we could be.
No,
But
that's
yeah,
fair.
I'm sorry,
Yeah.
I don't have those specific stats.
Yeah. But so not everyone, right? So I think that's one of the things we see in congenital heart disease a lot is that when patients become pregnant, they may have been lost to follow-up or lost to care, but then that's a way to re-enter. So if we could use endocarditis as a pathway to re-enter patients into care or engage with a program like yours, that would be beneficial for everybody, I think.
Any other questions in the chat? Question in the room.
Can you comment on the sort of number at risk? So you said 3,000 are experiencing homelessness. How many are actually at risk for infective endocarditis? And then how many present in or wherever they manage to present?
Yeah, so that's a lot of extrapolation.
Yeah.
So of the 3,000, and this is again extrapolating data more from Quebec than Alberta, but about 20% of people experiencing homelessness have a drug use disorder, so 30, it's a higher rate of alcohol use disorder and a lower rate of drug use disorder, so about 20%. And then if we say that maybe 5%, and that's probably a low number, are people who inject drugs, then that would be so I would say probably at least 5% of those 3,000 are at risk of drug use infections. And that's not just us either. That's osteomyelitis and skin and soft tissue infections, and yeah.
So this is towards double digits. Is this something that's feasible to manage with one dedicated physician?
Like having an endocarditis physician?
Yeah, for this at-risk population to at least be the point of entry into a care pathway.
Yeah, I mean, I think it would be, and I think that's something to consider for sure. I don't know that there's anybody in our division that's like specifically interested in this. I know Corey, Dr. Adams from surgery is interested in the infective endocarditis population. But yeah, I mean, I think we need to really start tracking outcomes and that we all have these patients in our population, or we all have these patients in our practice because you're on service and you see these patients. I'm at PLC, so I pick up a lot of patients with infective endocarditis, but it's certainly not my area of expertise, right? Some of them end up in the valve clinic where they're followed long-term, but again, is that the right place for these patients? So yeah, I think a robust discussion about how we manage patients experiencing homelessness with a history of endocarditis is important. Yeah.
Corey's not here, so you should sign him up.
Yeah. Okay, fair enough. Yeah. Okay. Any other questions or comments? And I think just for everybody in the chat, Aiden has entered the person to connect with at CUPS Calgary if we wanted to send a referral. So we'll make sure we copy that and make that available to our teams.
Thank you for a very stimulating talk and the discussion.
Thank you so much for engaging with everybody. Have a good day.
I guess blowing up people that bring drugs